From Stockholm, Sweden, this is CardioSource video news coverage of ESC Congress 2010.
Well, Fred, there were a number of really interesting trials presented at the ESC today. One that was particularly interesting was the Averroes trial, and this was a study that aimed to determine whether apixaban, an oral anti-10 agent, would be superior to aspirin in patients with atrial fibrillation who were not candidates for warfarin therapy for one reason or another. And so this was a randomized trial. The patients were placed on either apixaban or aspirin. They were followed for at least 12 months, and the endpoint was evidence of stroke or systemic embolus. And at the end of this trial, it was clear that apixaban was superior to aspirin. In fact, the rate of major endpoints were 3.9 and 1.7 respectively. So this is really an exciting development, Fred. It appears that in patients with AFib who can't take warfarin, that we have a really good alternative.
Well, we've been looking for alternatives, and I can tell you that the patients are always bugging us about getting off of warfarin and taking something else. So we're looking for an oral alternative that will give us, the relief from all the rigmarole that goes along with warfarin testing. So this is a very important piece of information, and I think we'll see it coming down the road.
And in fact, there's a study going on now where apixaban is being compared to warfarin itself. And it will be very interesting to see if, in fact, we do have another alternative to warfarin in the patients with atrial fibrillation.
I think it's going to be a major step forward and a big relief for patients when we get these drugs on the market.
And?
Well, in talking about anticoagulation, I think the other interesting study was the Einstein study, which looked at a comparison of a medication post, let's say, surgery for preventing DVT. This again was an oral factor 10 inhibitor, which was used post surgery and compared to an injection like unfractionated heparin followed by warfarin. This is a single oral dose of rivaroxaban, and you could take this orally through the surgical period of time and then afterwards. And what they found was non-inferiority, so that instead of an IV therapy followed by a long-term oral warfarin type therapy, you can use this one oral medication from immediately post-op for up to a year and show no difference in outcome from the standpoint of deep venous thrombosis. So I think this is another interesting anticoagulation area that's going to make some changes in the way we practice.
Yeah, and I think this is the traditional pathway for these drugs. First in DVT, and then ultimately I think we'll probably see it for atrial fibrillation, perhaps ACS as well.
Right, and I think the whole of the trend moving toward oral anticoagulation that is not a vitamin K inhibitor is moving forward in a very compelling way. And as I said, the patients are the ones waiting for this most.
Now, again, talking a little bit about atrial fibrillation, the anti-PATH study was presented, and this was a randomized, controlled, prospective trial of whether or not the use of an angiotensin receptor blocker, in this case olmesartan, was a superior or provided additional benefit in preventing atrial fibrillation. And this question has been debated. The data have been somewhat mixed, and so this was a large prospective trial. And the patients had atrial fibrillation. They were matched for whether or not they were on beta blockers, and there were no other renin-angiotensin receptor blocking agents applied. The patients were followed for 12 months, and what was notable is the patients had 1-minute electrocardiograms performed on a daily basis, so that it wasn't exactly continuous electrocardiographic monitoring, but it was very excellent surveillance. It wasn't just depending upon a patient reporting symptomatic arrhythmias. The bottom line, the take-home message was, in fact, there was no benefit of giving the ARB olmesartan in reducing the time to first atrial fibrillation or the cumulative time that someone spent in atrial fibrillation. So a negative trial, but I think probably an important one.
Well, we've been seeing literature suggesting the use of an ACE or an ARB is, in fact, something you should consider for treating AFib or preventing AFib, and I think this sort of puts some perspective on this, and in fact, it may not be the solid information that we'd like to see for using an ACE or an ARB in this therapy. I will say that, so much of AFib is driven by hypertension that you wouldn't want to neglect the use of an ACE or an ARB for treating hypertension, but again, this wasn't what the study was all about.
Right, and there are a couple important caveats. The patients did not have structural heart disease, and these were patients who already had atrial fibrillation, so it remains unknown if you treat patients early before the first episode whether these drugs may be beneficial.
Right, and I think, again, that's something that is going to be important in our long-term care because the use of these medications is very important in the management of hypertension and other types of heart disease and prevention. So, again, the more data we have in this area, the more it helps us in our decision-making.
Sure.
Now, talking about AFib, there was a very interesting study that came from Denmark looking at how you manage sick sinus syndrome, and the reason I mentioned AFib is because one of the findings was that if you use single chamber, that is atrial pacing, to treat sick sinus syndrome, that there's a significant downstream incidence of atrial fibrillation that occurs with just single chamber pacing. The study compared single chamber pacing to dual chamber pacing, that is atrioventricular pacing, and found better outcomes. They found less AFib, they found less progression to heart failure, and they also found less need to insert an extra wire to pick up on the ventricular pacing. So that study basically suggested that we should not be doing single chamber pacing.
That seems a bit surprising to me, Fred, because the David trial and most other studies that have been done that looked at ventricular pacing specifically have shown a worsening of left ventricular function and in some patients even the appearance of heart failure. So it's a little bit unexpected that here ventricular pacing would be better than just atrial pacing.
Well, I think, again, we've, over the years in trials that we've seen over 4 or 5 years now, have really begun to understand that single chamber right ventricular pacing may not be good for the heart, even though it's good for the rhythm. And I think everybody's being careful about where they place their atrial leads and thinking about biventricular pacing in lieu of single ventricular pacing. So this study at least is saying that if you have to deal with atrial and ventricular pacing, that if you do dual chamber, that is atrial and ventricular pacing, you have a better outcome than if you just put an atrial wire in for sick sinus syndrome.
And actually in these sick sinus syndrome patients, those are the patients who really don't need a ventricular wire, and if you could get away with solely an atrial wire. So disappointing results, somewhat unexpected, and I think I may stand back and wait for this study to be confirmed before I act on it.
Yeah, I would agree with the same. It does sort of conflict with some of our concepts from previous trials. So again, it's about a 700 patient study. We need more data, and I think you're right. I wouldn't make any major changes in clinical management based on this one trial.
Yeah, now moving on to the topic of acute coronary syndrome, the OASIS 8 trial was presented at this meeting, and it dealt with the issue of how to use heparin in conjunction with fondaparinux in patients who had non-STEMI. And the OASIS 5 trial, which was a major clinical trial, had shown, in fact, that fondaparinux had some advantages over enoxaparin, particularly in terms of bleeding. But one of the problems that was defined in that particular OASIS 5 study was a higher incidence of thrombosis, particularly catheter thrombosis in patients who were undergoing intervention. And it was subsequently determined determined that the addition of heparin to the fondaparinux could prevent this. So the OASIS 8 trial at this meeting aimed to define the optimal dose of heparin to be used, and they compared a low dose of heparin, 50 units, I suppose you might argue whether or not that's a low dose, to standard dose heparin, which was 60 to 85 units, depending upon whether or not a 2B3A agent was administered as well. And what these investigators found at the end of the study was that both heparin regimens given on top of fondaparinux in non-STEMI patients undergoing PCI were effective and safe. Effective in reducing ischemic events and safe in terms of reducing bleeding. And somewhat surprisingly, the low-dose heparin had no advantage over the high-dose heparin. So it raises a lot of questions. Why doesn't a higher dose of heparin cause more bleeding? And, of course, the second question, is it really worthwhile to give two agents, that's fondaparinux and heparin, rather than one agent, enoxaparin alone? But nevertheless, if people are going to use fondaparinux for the benefit shown in OASIS 5, probably a standard dose of heparin ought to be continued to be used.
Well, you know, it's interesting because good old unfractionated heparin seems to be surviving all these complicated trials, including the 10A inhibitor trials, the 2B3A inhibitor trials, a whole bunch of these. No matter where you look, somehow or other, unfractionated heparin seems to pop up again as something useful.
Yeah, it does. Earlier in this meeting, there was a study that showed that, in fact, the use of enoxaparin in patients with STEMIs was superior to unfractionated heparin. So we may see a lessening, but I agree with you. Heparin has managed to stay around.
Mm-hmm. Well, talking about acute MIs, I thought there was a very interesting trial called the RESPONSE trial, which looked at the post-hospital care of patients that had acute MIs in the hospital based on nursing care. And this study was a very interesting study. It used the SCORE, the European SCORE measure, which is a cardiovascular risk score measure. And what they did was they had two groups of patients, one that received usual care, go home, come back every now and then, to a system where the nurses had the patients come back 4 times in 6 months for a review of their risk management, of their diet, of their weight control, their cigarette smoking. And at the end of a year, this 6-month period was the intense period, and then the patients were back into normal care. At the end of a year, the patients that had visited with the nurses 4 times in that first 6 months had a significant reduction in their SCORE percentage, their risk percentage. It was about a 17% reduction. So I think it points out that some sort of more intense follow-up post-hospitalization for acute coronary syndrome comes out with a better risk at the end of a year than just putting the patients back into a routine system of care.
Not surprising that more intense care will do better than less intense care, but I guess we'll have to see if really lowering the risk factors, which is a surrogate, will result in a lesser number of events. So exciting kinds of data at this ESC meeting. For CardioSource Video News, I'm Tony DeMaria.
And I'm Fred Bove.
So be sure to join us again on September 22nd in Washington, D.C., where we'll have full team coverage of TCT 2010. Thanks for watching.